Hello, welcome to Men's Health Connected. This is our last day of Men's Health Connected for our 2022-2023 season. I'm Glenn Poole of the Australian Men's Health Forum, and today we've got two events in our Time to Act on Male Suicide stream of talks, today focusing on the national picture. I'd like to start by acknowledging the traditional owners of the lands that we meet from today around Australia. For me, I'm joining you from the lands of the Belai, the Gureng, the Gurengarang, and the Tarablang Bunda nations. That's up here in central Queensland. So, thank you for everyone who's jumped on and made time on a Tuesday morning in the last week of the financial year, to have a bit of a chat about the male suicide picture in Australia at the moment. Today's short presentation is to formally launch our latest report in the Time to Act on Male Suicide series. We are steadily producing a series of reports around male suicide across every state and territory. And this today focuses on the national picture. The way we're approaching that is we are observing when states and territories are renewing their suicide prevention strategies and seeking to launch a report to coincide with that. So far we've had, in the last 12 months, we've had consultations in Tasmania and Victoria, and we're currently quite far into the current consultation on the next national suicide prevention strategy, which is why we've put the national report out there. So, without further ado, I'll get our presentation up and share with you the key messages within our national report about male suicide across Australia. So bear with me as I share my screen. Okay, so this is basically a summary of a report that's available to download on our website. Hopefully, one of the team will share a link to that in the chat box. We've also got a petition on there if any of you want to sign the petition, and also some other resources such as social media tiles and an infographic which can be useful for raising awareness for those who want to do that. So most of you will know this stuff, I'm sure, but just a refresher. Suicide is a serious issue for men in Australia, being the leading killer of men under 55 still. Still 3 in 4 suicides, 75% of suicides in Australia are men. At the moment, the current rates we have there's about 8 suicides a day, 6 men, 2 women. And looking at the numbers of suicides over the past 10 years, from 2011 to 2021, which is the last full year that we have figures for, the numbers have increased about 30%. Broadly speaking, the rates of suicide haven't altered so starkly. That's the number of suicides per 100,000. But the actual numbers are going up. Partly that's due to population. But we're expecting, whilst there's been a dip in the last couple of years, there's a bit of a dip during COVID. All the strong evidence coming particularly out of New South Wales and Victoria suggests that the figures for 2022 will be the highest number ever, or certainly very, very close to the highest number ever. So around 2,500 suicides, closer to 7 male suicides a day. So it's also worth noting that whilst the actual rate of male suicide haven't changed that much over recent years, what we've seen at the same time is a significant reduction in the other things that kill men early. So things like road traffic accidents, heart disease, different cancers. While the rates of these are broadly going down, male suicide has remained stubbornly static. It does fluctuate up and down across the years, But looking back over about 100 years, the first time we had sort of data on male suicide rates in Australia, you find that the rate of suicide was about 18 men per 100,000 over 100 years ago. It's gone up and down, and currently it's around about 80 men per 100,000. So it's a stubborn social problem that we haven't managed to really make a significant dent in, despite all the focus and investment on suicide prevention over recent years. We've looked a lot at how suicide prevention is funded in the last sort of 4 or 5 years, particularly. This is not completely true of all suicide prevention funding, but we found that repeatedly this figure tends to show up, that while we know 3 in 4 suicides are men, up to 4 in 5 beneficiaries of government-funded suicide prevention initiatives are women, which means that we're targeting most of our funding towards services that are much better at reaching women and girls than they are at reaching men and boys. Now, to be absolutely clear, if it needs saying, we in no way advocate for any funding to be taken away from support for women's mental health or the suicide prevention initiatives that support women. With 2 women a day dying from suicide, it's a significant issue that we should be concerned with for women as well as men. The point we make, though, is that at the moment, the way that we're directing funding is not reaching significant numbers of men. There's 2 ways to address that. One is you target more funding specifically at male suicide. The other is that you actually require those initiatives that you fund to do more to reach men. What doesn't work is saying, well, men aren't accessing the services. To put the blame on men in distress for not accessing services that have not been set up with their needs in mind it just doesn't work. It's morally and ethically the wrong way to go about it. And yeah, we want to shift in how we approach male suicide. Then funding and how we attribute funding is definitely one of the mechanisms that we need to focus on. The most recent large tranche of government funding, this was prior to the election last year, was a total of $1.8 billion. There has been other funding allocated in previous budgets in the first year of the Labour government, but this bit of funding is particularly interesting to look at because it involved all state and territory governments. So it's a combination, if you've got a political mindset, it's a combination of both coalition and Labour governments. So 9 governments in total, the federal government working in partnership with all state and territory governments to allocate $1.8 billion of funding towards suicide prevention and mental health just before the last general election, federal election. Assessing that, both at a national level and a state and territory level, we find the same pattern over and over again. The majority of services funded have a track record of being much better at reaching women than men. All of them individually, perfectly good and appropriate services, but a real dearth of any type of focus on making sure funding is reaching more men and boys. And indeed, within that federal agreement, 15 priority populations are called out as being vulnerable. Men are not included on that list. Though to provide balance, it's fair to say that a number of the groups named would be mostly men, for example, veterans or people engaged with the criminal justice system, but men are not specifically called out as a priority population. So at a strategic level, we're not requiring governments to ask themselves the question, how do we make sure that our services are reaching more men? Nor when we look more broadly at what's happening at a policy level, is male suicide being called out in any other sort of major policies? So there's a development of a national gender equality strategy. Male suicide is not mentioned in that as an area of concern. And there's the development of a well-being framework for measuring what matters, which is run by the Treasury. The importance of that framework is that that aims to drive how all government funding is targeted over the next many years across all departments. And we're finding that there's a lack of focus on just broadly on men's health or men and boys issues in that particular strategy too, with male suicide again being one area that's not being flagged up. So in most of the mechanisms that are available to government to sort of direct more focus and funding towards male suicide prevention, we're seeing there's a complete absence of focus. And this seems to be at odds broadly with what the general public think should be happening. We did a nationally representative survey a couple of years ago, looked broadly at a range of health and social issues and on what the public thought about those. Vast majority of people actually recognise that men and women face different social issues. I think it's okay for the government to be focused on these for men and for women. People say we shouldn't be ignoring the differences between men and women, and the vast majority, 4 in 5, that's women and men, by the way. This is not an area when you talk to the general public, this is not a men versus women issue. It's not like all men are saying, yeah, more money for men, and women are going, no, we want all the money, keep it for us. Men and women fairly equally support the idea that we should actually have more funding directed specifically to a range of men's health issues. And when we ask what are the most important issues you think that men are facing, mental health and male suicide come up as the top two. So there's strong public support broadly for more focus on men's mental health and male suicide prevention. And that bit about recognizing differences is really important in suicide. The difference isn't just that the men are 3 times more likely to take their lives. The pathways to suicide for men and women are very different, but or have distinct differences that need to be taken into account. Put simply, women's suicide is more likely to be linked to a mental health diagnosis, and men's suicide is more likely to be linked to a range of situational stressors. And there's a big overlap in those. So we don't want to create a binary view of male and female suicide where we say female suicide is mental health issues and men's is situational. There's a really broad overlap, but there's a strong enough distinction between those two for us to actually to explain why men who die by suicide often are not turning up in mental health services, because many of them take a pathway to suicide which isn't through a lens of a mental health diagnosis or issue. So you'll mostly be familiar with this type of stuff. There's issues like unemployment, legal issues, relationship problems, money issues, drug and alcohol abuse, child custody challenges, and so on and so forth. And in those categories of suicide, men are heavily overrepresented. There's no, and we're picking up this data from different bits of research in different states and territories. In fact, not listed here, but in the report, we mentioned the fact that the Queensland Suicide Register estimates that 98% of all suicides have at least one life crisis associated with it. So even for women, the simple view that suicide is the result of a mental health issue or diagnosis is too simplistic to understand the complexity of suicide. The vast majority, 98% of people who suicide, according to the Queensland Suicide Register, will be experiencing one type of life crisis. Now, does the life crisis lead to the mental health issue? Does the mental health issue lead to the life crisis? And the answer is both. It's complex, but only viewing suicide, particularly for men, only viewing suicide through a lens that it's a mental health issue, and men not talking about their mental health or not accessing mental health services as the problem is not going to resolve the challenge of male suicide. We need to take into account these other situational factors and how we respond to those as a society. And the whole narrative that the problem is men not getting help is really unhelpful. It's a gender stereotype. It's stigmatizing of men in distress. And it's simply not backed up by data. Yes, some people who die by suicide will not have access services, both men and women. But to simply say that men who suicide aren't getting help, and therefore what we need to do is get men to get help, again, is not going to solve this complex problem. Looking at the National Mental Health Survey, we've seen an increase of about 30 or 40% in the number of men with mental health issues accessing support in the last 10 to 15 years. So we're seeing a constant increase year on year on the number of men with mental health issues accessing mental health support, counsellors, psychotherapists, so on and so forth. But we're seeing no reduction in male suicide. So the connection between those two actions, it doesn't follow that getting more men into mental health support equals less suicide. There is a clear distinction in terms of those who are more or less likely to access mental health services. And not surprisingly, those people who suicide, who had a mental health diagnosis, depression, anxiety being the key ones, 90% of them, research has found, would have been in contact with a mental health specialist in the last year. And that's men and women. The issue is, so you have a bunch of people who suicide who actually have been in contact with services, and for whatever reason, the support that they're getting from those services hasn't made the difference that needed to be made. So to say that they weren't getting help is a complete dishonoring of the pathway that those men took to suicide, because they had a mental health diagnosis, they accessed help and support, and then they suicided. So to say the problem is they didn't get help is completely to misdiagnose the problem. Well, there is some surface truth in the idea of men not accessing help is in the group of men who are categorized as primarily experiencing situational distress. Now, it shouldn't be surprising that in the group of men who don't have a mental health diagnosis but are dealing with other life stressors, that most of them wouldn't access mental health support. Why would they? They weren't dealing with a mental health issue. They were dealing with relationship breakdown, financial issues, unemployment, whatever they were dealing with. But even in that group, about a third will have accessed mental health support. Also, we find that those men are showing up in other parts of the system. So nearly half across all suicides, nearly half have been admitted to hospital, not necessarily for mental health issues, but accident and emergency, or through ambulance call-outs. More than 40% have been in contact with housing and welfare services, many more in contact with GPs, legal services, community service providers. This data is a little bit sketchy because it's not all a national picture. We've picked little bits and pieces of this from different bits of research in Tasmania, in Victoria, and nationally as well. The references are in the national report for you to look at. But the basic message is that most men who suicide have had some kind of contact with the system. A significant chunk with mental health providers, another chunk with general health providers, and another chunk with broader sort of community and social services systems. So we believe to tackle this complexity that simply rather than doing more of the same, which is to do more of that mental health prevention work, is that we actually need, and I hope that it reaches more men. In addition to that, we believe we actually need a specific suicide prevention action plan. It could be a strategy, could be a policy, could be an action plan. It doesn't matter what you call it. What's important for us is that nationally, those responsible for doing suicide prevention actually go through a process of thinking about how are the services that we're commissioning and the actions we're taking going to work or not work for men and boys. Because we know when they don't ask that question, what happens is a whole range of services which are more effective at reaching women get commissioned. And then all that we're left to do, or the only option we then have, is to then point the finger at men for not accessing those services. Now, I don't actually have an objection to that if it works. If it works to go, oi, distressed suicidal man, call Lifeline. Distressed suicidal man, call Beyond Blue. Distressed suicidal young man, go to Headspace. Distressed suicidal young man, go to your GP. If that works, let's do it. Because frankly, I'm really interested in what's going to prevent suicide, what's going to actually address the fact that today and tomorrow and the next day and next week, every single day, 6 men in Australia are going to take their lives. If getting a bunch of AFL stars on TV every night saying, blokes, go to a psychologist works, let's do it. The reality is that's not the solution. Of course, more awareness, more encouragement and help seeking can be part of the solution. But suicide, male suicide, is far more complex and needs far more intervention than that. It's no good pushing more men into services that aren't actually equipped to respond to their needs. So we've been saying this, and my predecessors have been saying this for a long time, but there is growing support for this approach. We've certainly seen a theoretical shift in the approach to suicide prevention nationally in the last few years. A recognition that suicide prevention isn't just a mental health issue, but there's a whole broad range of social contributing factors. You could see that in the appointment of Scott Morrison's National Suicide Prevention Advisor. There's been a concerted and genuine effort to try and make suicide prevention a more cross-department approach and look at how other parts of the government system can actually contribute to suicide prevention. And we have the peak body for Suicide Prevention Australia, acknowledging that male suicide is an issue requiring targeting policy and funding, which is a position they didn't have 3 or 4 years ago. And there's a lot of great stuff in Christine Morgan. That was Scott Morrison's National Suicide Prevention Advisor. Her final report includes a lot of great stuff about how we need to focus on male suicide, including calling for all governments to actually review how well their services are doing in terms of reaching men. Which is something we haven't seen happen yet, and something we very strongly support. So the big question for me is, how do we actually send a signal to men, that particularly men who are in distress and at risk of suicide? How do we as a society send a signal to them that we're on their side, rather than just a message that they need to open up and get help? How do we send a message that we've got their back? That is one of the reasons why we need a male suicide prevention action plan. It's a signal from the top of government which says we care about this issue. Taking gender out of the conversation of suicide and saying we're doing all we can to prevent suicide, but not acknowledging that 3 in 4 suicides are men, and not actually actively saying we're going to do something about the fact that 3 in 4 suicides are men, by default sends a signal that we're not really focused on it. You could say it sends a signal that we don't really care. And so just symbolically, the very act of saying we are specifically focusing on male suicide is a really good start, but it needs to be more than a symbol, but it's a good start. In terms of what such a strategy might contain, there's lots of different things. We recognize that a lot of the factors that lead to male suicide are actually outside of the remit of mental health services and the health system. It's things like the economy. It's how we manage relationship breakdown. It's even stuff like the level of education we give to boys. And this is true across all health. The worse your educational outcomes as a boy, the worse your health as a man. Broadly speaking, if you don't get a decent education, you're at greater risk of suicide later in life. And currently, the school system is less effective at educating boys than it is at educating girls, which is why I make the case that actually actively working to improve boys' education today is one of the key things we need to do as a society to improve men's health tomorrow. People struggle with this concept. It's quite a simple concept, right? But when I talk about that, people will then go, no, we need to teach boys to be more emotionally expressive and share their feelings. And I'm like, well, yeah, but that's not what I'm talking about. I'm actually talking about reading and writing. I'm talking about literacy and numeracy. I'm talking about the results you get in education. I've stumbled across some interesting Australian research the other day, which showed that I think, let's get this right. Yes. So at the age when we're born, male and female life expectancy is now down to about a 4 or 5 year gap. About 25, 30 years ago, it was more like 5 or 6 years. So if you take as an illustration, if you take a boy and a girl in the same family, same background, go to the same school, same mum and dad, same neighborhood, their life trajectory will result in the brother dying about 5 years younger than the sister. That in itself is cause for concern. What are we not doing for the boy that we're doing for the girl? What more can we do for the boy to help him live a longer, happier, healthy life? But when you measure those same people at the age of 25, you find that the gap can close or widen based on education. So for young men and young women at the age of 25 who've got a postgraduate or master's degree, the life expectancy gap nearly disappears. But for those who don't have a high school education, so they leave year before the end of year 12, they can now expect to die 10 or 11 years younger than the men and women with a postgrad degree. So education predicts our life expectancy. And education, our economic circumstances and our family circumstances, they all actually are part of suicide prevention. Because if we improve the economic well-being, the education, the housing, and all the rest of those things of society, that actually reduces risk of suicide. Doesn't end it, but it reduces the risk of that. Now, realistically, you're not going to get a national suicide prevention strategy which reforms education, transforms the economy, reforms the way that we do family law and all those other activities, which are important activities, but cannot be managed within the context of a national suicide prevention strategy. So in terms of the areas we're identifying, there are things that can be within the remit of a national suicide prevention strategy. And the first thing is, we need, in line with Christine Morgan's recommendations, we actually need governments to review what they're doing. There's all sorts of different ways you can evaluate and review. There's a particular approach which I think should be adopted for male suicide, and that's an approach called gender impact assessments. Gender impact assessments have been happening for years. Australia's led the way in taking a gender responsive approach to budgeting. Been doing that for over 40 years. Though it's pretty much entirely been focused on identifying how the way government spends money can impact women and girls positively or negatively. In terms of the mechanism, there's no reason why that can't also be applied to men and boys. This new government is particularly strong on doing gender impact assessments for women and girls. I think a gender impact assessment on our male suicide prevention and mental health funding would be very revealing in terms of the way that we're approaching this. Clearly, by any objective measure, is not effective. So that's one thing that I'd really love to see. The very base is just to assess what are we already spending money on and how effective is it at reaching women and girls, men and boys. There's been a massive growth in the inclusion of people with lived experience in mental health and suicide prevention, which is really welcome. My anecdotal perspective on this is that men broadly are underrepresented in the lived experience space, and of those men that are in the lived experience space, there's probably a strong bias towards men with mental health experience, not so much men with situational experience. So you won't find many men who, in the lived experience space, talking about their experiences of homelessness, the criminal justice system, workplace bullying, unemployment, family breakdown. It's mostly men talking about their experiences with different mental health challenges and dealing with the mental health system. So I don't have any hard evidence to back that up, other than just being in the space and observing the different people who are doing lived experience work. But I think that's something to be explored, that not only do we need to get more men into the lived experience workforce, but also a diversity of men that represents not just those sort of mental health pathways to suicide, but also more of those situational pathways to suicide. I very strongly believe that we need to put more weight and funding into grassroots projects that are run by men and for men. Australia is extraordinary in its approach to men's health. We have been very pioneering. We have things like the Men's Sheds movement, which emerged out of Australia and has spread around the world, an initiative run by men for men. 30 years ago, there weren't any men's sheds. Now there's more men's sheds in Australia than there are McDonald's. Now, at the same time, in the last 5-6 years, we've seen an explosion of grassroots projects led by men for men that are promoting mental health, social connection, mateship. They've not yet been collectively recognized at a sort of funding level or a policy level as being as valuable to men as men's sheds are. And I think they need to be recognized. It's because we talk about, what men aren't doing, but one of the things that men are doing at a grassroots level is stepping up and saying, we want to support the men in our community. We've got initiatives like the Man Walk, Mr. Perfect, the Men's Table, Grab Life by the Balls, Sam, I'm not going to leave you out, and lots of smaller individual groups in communities all over Australia that are providing social connection and support for men. And I think that is such a valuable community resource that we need to be putting wind in the sails of that movement. I call it the grassroots men's mental health movement. Also more professionally focused initiatives that go into workplaces, such as Mates in Construction and AusHelp. And I think that's one of the principles of men's health work is we should be directing support at places where men already are, rather than expecting men to turn up in services that haven't been designed with them in mind. We need to be targeting services, doing outreach to places where men are. Workplaces are an obvious one, but sports clubs, places, the barbers are another one. There's pubs. There's a whole range of initiatives that can be supported and funded to reach out and go where men are. And also, we need to be really smart in actually recognizing that supporting men going through relationship breakdown, supporting men with financial issues, supporting men in the legal system, supporting men who are having housing issues or homeless, supporting men with drug and alcohol issues. This is suicide prevention. The suicide prevention doesn't look just like one-to-one sitting with a counselor or a psychotherapist. If we want to prevent male suicide, we need to recognize that a lot of suicidal men present with a range of other issues, not their mental health. The example I give of this is having worked in and around groups working with separated dads in the UK and Australia for about 20 years now. I've spoken to hundreds, if not thousands, of men going through separation over the years. I've never once had one pick up the phone and say to me, I'm going through separation. I'm worried about whether I can see the kids. I don't know what to do about the house. I don't know what my legal rights are. I need to get some mental health support and talk to someone about my feelings. Never had that conversation. What it's always been is, what are my rights? What can I do? I need advice. I need support. And so that needs to be honored. That's an example of men. When men are often reaching out for help, they're just not reaching out in the ways that we think they should. So they're reaching out for help by saying, I'm in trouble here and I need to know what to do. Well, then often not doing is saying, I'm in trouble here and I need to talk to someone about my mental health. Now, my experience is also that when you actually meet that need, and sometimes it can be expressed in real distress, in ugly language, with anger, with upset, but when you meet that need and respond to what men are asking for, you build trust, you build relationship, and underneath, there's often an opportunity to get into the emotional support, the mental health support, and all the rest of it. But the first point of call, when a man's dealing with all that situational distress, we need to deal with the thing that's distressing him. We need to do sort of a triage approach that actually says, right, what is the biggest problem you're facing right now, and how can we help deal with that or mitigate against it? Three more. So I strongly believe that we need to look at the mental health and suicide prevention workforce, both in terms of professionals, volunteers, and people trained. Whatever assessment we've done on that finds a figure consistently of 70 to 80% of people working in mental health and suicide prevention being women. There's a massive opportunity there to diversify the workforce. It's a key principle of diversity that public services should be provided by people who reflect the diversity of the populations they serve. Now, this is not to be critical of any of the women doing amazing work in psychology counselling, mental health support, telephone counselling, and all the rest of it. But it's to acknowledge that the workplace does not reflect the diversity of the community it serves. And particularly in suicide prevention, surely we need to ask ourselves, does it work to have 3 in 4 mental health workers, suicide prevention workers being women, when 3 in 4 people who suicide are men? Is there a missing there? And you find it reflect even in the voluntary space and even in the training space. So when we go out and do gatekeeper training, how to look out for someone who's at risk of suicide and how to support them, when they actually measure it, usually the figure I see over and over again is 70-75% of people receiving that training are women. So again, this is not to say we need to stop any of that work with women. It's not to be critical of any of the women doing amazing work in those spaces. It's to say that actually we can get more men involved. The first way to do it, I've already mentioned, is actually to put more support into those volunteer-led, community-based groups run by men for men. But there's lots of other opportunities to get more men into mental health and suicide prevention. If we don't name it up as a problem, we won't seek to find the solution. There's certainly a need to actually look at existing services and say, how can we actually train and support those working in existing services to deliver services that are appropriate to men, because we know men are turning up in mental health services and often actually dropping out because they're not getting the support they need. Some good practitioner training is emerging, particularly Men in Mind from November, which is, I believe, going to be freely available in the not too distant future. That's a really positive step forward. But also, I think we need to be looking at more of a cultural and systemic approach to making services more male friendly. It's too much to put it all on individual practitioners and say, if you just change your approach, things will get better, if the service or the system they're working in isn't also taking action to become more male friendly. Simple actions like actually promoting your services more directly at men, for example, will get more men through the door. But you can't just do that. You have to make sure that when men come through the door, the service they receive is culturally appropriate to them as a man. And finally, leadership. Take me to your leader. If you're really concerned about male suicide in Australia and you want to go and knock on someone's door and say, okay, how's it going? How can we help you? There is no one to go to. As in, there is no one specifically tasked with the role of male suicide prevention or men's mental health, not a minister, not a commissioner, not a task force. And that's a missing because who do we hold accountable? Who do we support? Who do we look to actually put action into place? So, we would like to see not just a policy, but a named person with responsibility for delivering and improving that policy over time. So, that's taken 40 minutes in a 45-minute session. We're going to have a whole hour or so from 10:30 discussing more broadly the emerging national suicide prevention policy and whether any of this stuff is going to be in there and how we can try and get some of this stuff into there. I'm going to look at the chat box in a second, but I'll also ask one of the team just to post a link again to the resources that are available so you can download this. And we've got about 5 minutes, so I'd like to give a couple of people a chance to jump in and respond. And Sam Parker, as you've got your camera on and on my screen, you're right underneath me. Oh, you're in the library though, aren't you? But I just wondered if you wanted to jump in and say anything from a sort of grassroots men's organisation perspective.
Just thank you. The big slice of the pie that's missing, and it's great that these stats support that, and we know that on the ground that this is going to make a difference, and simple things will do this, and a male-specific policy will help this as well. So thank you for the work that you do and all the data that you've got, and it helps us spread the message where we're at and what we're doing too. So thank you.
Thanks, Sam, and thanks for the work of Grab Life by the Balls. Go and pop a link to Grab Life by the Balls in the chat box so people can go and find out what you've been up to. If anyone's got any sort of questions or responses they want, pop your hand up. We've got a few minutes. I'm just sort of flicking through the comments here. There's been a lot of chat going on, which is fantastic. Comment from John Drain at Mentoring Men.
Hi Glenn, how are you going?
Good day, John. Good to see you.
Thanks for the sessions. Fantastic, and what a turn up. It's really amazing. I'm from Mentoring Men, and I'm in the Newcastle section of them. And so Mentoring Men provides mentoring to men who are living with anxiety, depression, or suicidality. And if you are in that space, you can join. It's all free. And you can join as a mentee, so needing help and progress, or even start as a mentor as well. So it has a kind of like a dual situation, because men who do engage as mentors in Mentoring Men have lived with suicidality themselves, and I've lived with suicidality myself. And so I'm 68 now and still alive and trying to help in this space is enormous. I'm also part of the Hunter Homelessness Project, and also aware of homelessness with women, as well as the main cohorts of suicidality octogenarian men, and also 40-something men. And my lived experience was when I was in my 40s with a young family, and so I can bring that and have helped younger guys like that. Just before I don't bore you with all the details, also women attend the mentoring sessions and the training sessions and are part of the process. And there's a strong emphasis on research by women into domestic violence that Mentoring Men interacts with as well, which is really important. So anyway, I hope that helps, and I've got the links there if anyone's interested. Thanks, Glenn. I really appreciate it.
Thanks, John. Thanks for the work that Mentoring Men are doing. Just a couple of acknowledgements in the comments. Good day to Billy Beggs at Penrith Men's Walk and Talk. Didn't give them a mention, but they're a fantastic example of a locally based grassroots organisation which is supporting hundreds and connecting to hundreds of men in the Penrith area. I also want to acknowledge Alan Woodward, who's not here anymore, but Alan Woodward is from the National Mental Health Commission, and so has connection to the development of the National Suicide Prevention Strategy. What does he say? Really interesting presentation today. Thank you, AMHF. We certainly need to do better in this country on male suicide prevention. And acknowledgement to Warren Davis, and by virtue of also acknowledging the need to focus on rural men. Warren is the unbreakable farmer. He says, got to shoot off. Very interesting content. Thank you. Thomas Hayes, RMHI. Can you tell us what RMHI is and jump in there, Thomas?
Yeah, g'day guys. Can you hear me there?
Yes.
That's working, yeah. Apologies, my voice is a bit crackly. I just tested positive for COVID, so I'm a bit under the weather. But no, thanks Glenn, for your presentation. Look, I pretty much agree with everything that you went through there. Look, whatever we're doing at the moment just isn't working, is it? We looked at the stats earlier on, and something's got to change. So I think just the way you're looking at it with that real practical approach is really important to see what's actually going to work in this space. But look, for those of you who don't know, I work for a group called Regional Men's Health. We're based over here in regional WA, trying to make a bit of a change in that space through education of those grassroots sort of led programs that you went through, Glenn.
Great, thanks. I was over in Perth during Men's Health Week and saw. I was expecting Terry to give a presentation, but it ended up being
Glenn, was it probably?
Glenn, probably.
Glenn would have been Glenn, yeah.
What's his surname? It wasn't me.
No, it wasn't. Glenn Darkinen, yeah.
Yeah, cool. Yeah, great work you guys have been doing for years, not just on mental health, but across all aspects of men's health. A couple of comments about the need for a Minister for Men's Health or Minister for Men in general. Dom, I think you were from the COFS Suicide Prevention Network. This presentation has been extremely valuable in terms of developing our community-based engagement framework, which includes supporting people with lived experience. We know we would like to engage more men in the community-based suicide prevention space, and I've learned a lot here about how to go about that. Right, we're just about to come to time. I see, Paul, you've got your hand up. Do you want to jump in and have a comment, Paul?
Yes, please. Can you hear me, everyone?
Yeah, we've got about a minute left, Paul. So yeah, just got time to squeeze you in.
All right, just quickly, two things. You have an alignment with Suicide Prevention Australia. Now, shouldn't the suicide prevention agencies be putting, 50% at least more advertising out there for these situational distress in men and things like that? I think that we've already have these established $400 million in funding. I think they need to lift their game a little bit. The Lifelines of Australia, Black Dog Institute, they're established and they're the leaders. If we need to get this awareness out there, they're the ones that should be helping us do this.
Yeah, I mean, I was certainly, individual organisations are free to do what they do, but in terms of organisations funded by government to do suicide prevention, I think there should be a requirement to report on what they're doing on male suicide. So, for example, Lifeline says, 35-40% of the people are reaching are men, and then you wouldn't stop funding Lifeline, right? But you would say ideally you'd say, okay, we're going to give you another 2 years of funding. Tell us what you're going to do in the next 2 years to actually start to increase that number. So you use funding as a way of actually putting pressure on organisations to in our language, to up their game. But they would use different language. What was the second point, Paul?
The second point is just I think all these organisations, we should be all aligning behind, as you say, having that voice, that representative. And we all know a Minister for Men's Health and Welfare is the best sentence said for that. We need to, like you say, we need to fix this situational distress in our youth and in our men. And it's not just a few $1 million; it's billions of dollars that need to be spent to get these things put in place. And I can't see that happening without that representation in Parliament. So yeah, they're my 2 points, and I just hope a lot more of these men's organisations can start talking more on the Minister for Men's Health and Welfare. We're laying down the 2,500 shoes on the lawn of Canberra Parliament House this year in November again to coincide with International Men's Day, and that's our theme. And we hope a lot of people can get behind us with that.
Great. Thanks, Paul. Thanks for your comments, and thanks for everyone who's joined us today. We're going to take about a 10-minute break now before we have a broader discussion on the National Suicide Prevention Strategy. Thanks, everyone who's participated. I'm going to go and read all these comments. And just a final reminder, please do go and download the report from our website, share some of the resources, and let's do a little bit more to raise the profile of male suicide prevention in Australia. Thanks all.